All right, this is going to be a quick video on some do's and don'ts. First thing I want you to do when you look at a patient chart before you get started in the morning is look at the medication list, the medical history, and the problem list. One of my biggest pet peeves is a problem list that looks like this. At your first glance, it looks pretty overwhelming. It looks like there's a lot going on. So the first thing I tell people do is start by cleaning up this problem list. So you can go over here to these three dots. And what I typically do is try to organize the problems in order of what I find to be the most important to the least important. So you'll see as we look at this, well, there's a lot of diagnoses on here. Look like this patient has a lot of problems, but under the current medications, they're only on 5 medications. So we should be able to whittle down this problem list just based on the 5 medications they take. And they should have an associated 5 medical history items listed that go with the medications they're taking. So this problem list and this medical history should almost directly correlate. So as I see here, this patient has diabetes, hypertension, hyperlipidemia, GERD, and depression. I'm going to go over here to this problem list before I get started. First thing I'm going to do is just reorganize it. So we'll start by grabbing diabetes and bringing that to the top. We know the patient is diabetic because they're on metformin. We see it in medical history. We see they're on olmesartan. They have hypertension. So let's see if that diagnosis has been added. There it is. Let's grab that and bring that up to number 2. And then they're on atorvastatin, which is on their medical history. They're on atorvastatin. It's on the problem list here. Let's bring that up to number 3. Number 4, looks like they're taking pantoprazole for GERD. Let's go ahead and bring that up to number 4 on the list. And then they're on Zoloft for depression. So let's see if we can find that. If we can't find it and it's not already on there, then you can always hit add ICD-9. You can put on here depression with anxiety or whatever code you're going to use. I'm going to add it even though I know that it's on this list because I just created the chart. So as we go down, we can go in here and find depression with anxiety. Let's bring that one up. Now we've organized these, the top 5 diagnoses. I always tell the resident working with me that you should be able to look at these 5 medications on the medication list. If we move the chart note and we try to line it up with the problem list, we should be able to almost draw a straight line across to understand why they're on each of these medications. There's always extenuating circumstances, but for the most part, I should be able to look over here at the problem list, go, they have type 2 diabetes, they're on metformin. They have hypertension, they're on olmesartan. They have hyperlipidemia, they're on atorvastatin. You should be able to just draw a line across from the medication list to the problem list. And then the medical history should correlate exactly with this problem list. Occasionally, we'll have things listed under the medical history on rare occasions that are not on the problem list. For example, I like to put in here that when their last colonoscopy was, just for a reminder. But in general, this medical history should directly correlate with the problem list. Now, let's go back to the problem list. These are what we're going to go through. The do's and don'ts. The do's are, first, organize the problem list in order of most important to what you would consider least important. We can debate this back and forth till we're blue in the face. That's not the most critical part. Let's try to make it in order with their medication list so that the medication list, the medical history, and the problem list all line up. The second part of this is, and this is one of the big ones that just drives me nuts, is when they have multiple diagnoses under the problem list, it's the same diagnosis. So if we go down here and we're scrolling through this problem list, I look down here and I go, oop, type 2 diabetes, well, that's already on there. Let's look around some more. Oh, there's type 2 diabetes again. So a lot of times what I'll do is I'll start grouping these all together. Okay, I'll see if they have multiple diagnoses of the same diagnosis, right? So we're going through here going, okay, those all look the same. Now, we don't need to have this entered 3 times. We just need to decide which one we're going to use, right? If it's diabetic with hyperglycemia, use that code. If it's not, you can take out the other 2 codes. And let's try to simplify this thing a little bit. We'll hit remove. Take them out. They're gone. Go over here. I see lots of things on the problem list that they're not on any medications for, and they're not under the medical history. So these might have been acute issues that someone added to the problem list for one reason or another. Most common reason they're added to the problem list in error is because they accidentally clicked something over here. I'm going to show you what happens. When they're adding in assessments for the day, we'll say this P here is the primary assessment for coding purposes. The number one issue of today is going to be diabetes. And all of these things here are things on their problem list. If the patient comes in today and also has an upper respiratory infection, URI, and let's just click upper respiratory infection, acute URI. I'll just put unspecified. When you're looking down this problem list of things we added on today, there should not be a check mark for a problem list by URI. Unless this is a chronic issue that the patient is going to be on a medication for consistently, and the patient is going to be coming back on a regular basis to get refills on a medication, it doesn't need to be added to their permanent problem list. What often happens, I think, is people go in here and they're adding codes. Like, let's say the patient was having an annual physical today, which, if that was the main reason for their appointment, annual physical should be at the very top. It should be the primary assessment. But what I often see what happens is people click this box here, the PL, that means problem list. You should almost never click this box, because what it's going to do is it's going to add all of those assessments. Okay, it's going to add them all. Most of the time people hit add or replace. Let's put replace this time, but it's still going to add all of those assessments onto their permanent problem list. So when we go over here on the problem list in the chart, now we've added annual physical exam. We've added annual physical exam to the permanent problem list. Let's take that one off. We've added another diabetes diagnosis up here. Let's make sure diabetes is at the top. As we go down, patients not on any medications for urinary tract infection. This must have been an old diagnosis. And someone had put dysuria also. Let's go ahead and get rid of those. It looks like at one point the patient had a cough. Today we accidentally added upper respiratory infection in there. Those don't need to be on the permanent problem list. Let's take those off. Again, rash. The patient's not on any kind of medication or creams for rash. Doesn't look to me like it's a chronic problem that the patient's getting continuity visits for every 6 months to get refills. So let's get rid of rash. Dietary counseling and surveillance. It doesn't need to stay on their problem list. It's not a problem. It's just a counseling code that someone used at some point. Let's get rid of that one. Status post below knee amputation of left lower extremity. Now, this may be one we want to keep. So let's drag it up and just hang on to it. We're not going to delete it. As we go down, we see the patient has some other codes here that are maybe overlapping codes like arthralgia, right hip pain, left hip pain. Patient's not on any medications for these. I'm going to take them off today. Now, if the patient tells us that, I'm going to remove them. The patient tells us, oh, I have a history of arthritis and I take over-the-counter Aleve, then what I would just do is add on the ICD-10 diagnosis of arthritis. If it's a chronic issue the patient's coming in for, I'd add it into arthritis and I'd drag it up here. Okay. Rhinorrhea, which means runny nose, nasal congestion. That would have gone with URI, but again, they're not chronic problems. Let's get rid of them. Someone used a code at one point for elevated blood pressure reading without a diagnosis of hypertension, but they also have a code of hypertension. Which one is it? The patient's on olmesartan, so I'm going to assume they have hypertension. I'm not going to keep elevated blood pressure reading without diagnosis of hypertension on here. It's not a chronic problem. So you see, we've already got this list down more narrow. Another thing people frequently do is they'll add on the problem list obesity or overweight. While it may be true that it's a chronic problem, I usually don't add that diagnosis because it can change. So suppose on today's visit, the patient is obese with a BMI of 30, but they lose weight. And the next time they come back, the BMI is 28. Well, you don't want to have the obesity diagnosis on there anymore because they're no longer obese by BMI criteria if their BMI is now 28. So I usually don't leave this on the problem list because it can change each time. It's not wrong to put it on there, but you have to make sure that you go and clean up the problem list when you see the patient. If the BMI has changed, go and take off obesity. It's not one of their chronic problems anymore. So again, first things first, just clean this list up. Now you can already tell now for today's appointment, when this patient comes in, it's already going to be less overwhelming because they have less problems on the problem list. You go, okay, we're going to be dealing with, looks like maybe 5 things here today: hypertension, diabetes, hyperlipidemia, GERD, and depression. So when we get down to our assessment, we can just use the codes for today's visit. If the patient's just here for med refills, we'll take off those. Those were the 5 diagnosis codes that the patient's here for. There's the five codes that they're coming in for refills today. We quickly can go to our treatment tab under the RX tab, go to our medication summary, and we can start hitting 90-day refills on metformin, 90-day refill for the olmesartan. We select hyperlipidemia, 90-day refill. GERD, 90-day refill. Depression, we're going to give them a 90-day refill. We're refilling the medications the patient has been on for a long time. We're giving them 90-day refills. And that visit's done very quickly. But at first glance, when you see this patient, you could have gotten very overwhelmed by all the diagnosis codes that were on there. I'm going to have a part 2 to this one, so we can keep these short. Thanks for watching.